Ah, ahora lo veo. Así, live, video en chat, ¿no? Está chévere. Así, live, video en chat, ¿no? Está chévere. Sí, creo que tiene, déjame ver, creo que tiene audio, ¿no? Archivo de video del PowerPoint de Richie. Así, live, video.
of COVID. So
Okay.
yeah.
Okay. It's already 7. All right. Hi everybody. Good morning. Thanks for joining to the ICS. This meeting is being held virtually because of COVID. Initially, we were thinking about having a meeting in Ecuador. We're looking forward to have everybody welcome in Ecuador. I'm from Ecuador, and Germán also is from Ecuador. And All right. We were really looking forward to have you, but because of the pandemic, this year is going to be virtual. We've been lucky to have a great group of panelists. The first session is about new technologies. Thanks everybody who was able to join, and thanks the panelists. They making a big effort joining the meeting. Some of them had to wake up at 4 a.m. to join. Also, it was difficult to coordinate the best time to have all the world join. There were some requests from our Japanese colleagues to make it even earlier. So I think Landon, you're not so unlucky. Having said that, I'm gonna let Herman, he's our co-host. He's in Quito, Ecuador. Say a couple of words to start the meeting, and then Duncan Maitland is gonna introduce Landon. Thank you.
Well, good morning to everybody, the people who joins now in this moment. I'd like to welcome to everybody to the meeting. I feel it's the new kind of meetings we are using now. It was so bad we couldn't meet in Galapagos. Maybe we will do it the next time after this coronavirus disease. I hope we have this Congress. I started with Daniel Rufenac and Pedro Lili, starting back in 2002, and I feel like it's a very good meeting. We learn something from each other. So welcome to everybody, and Duncan, please, you can introduce Landon. Thank you. I feel like.
Thank you. Welcome, everybody. And before I get started with Landon, just to clarify, you guys can type your questions into, it's not a chat feature, but it's in, I don't have that open. But you can type your questions in and they'll be relayed to the speaker. We are going to do all the questions for the first and third speaker during the discussion session. And Dr. Jaber's questions will follow directly so that he can get to business soon after his talk. I think that's how it's going to flow. Any corrections to that, Edgar? No, that's good.
That's perfect. Thank you. I forgot to mention that.
Okay. I'd like to introduce Dr. Landon Nash. He's a R&D manager at Shape Memory Medical. Shape Memory Medical is a company I'm associated with. And he's going to talk about Shape Memory polymer foam Trellix device that is a new coil, early experiences with that. Landon did his PhD, his undergraduate and his PhD at Texas A&M University. And he is a San Francisco Bay Area life science angel, a well-known angel group. He is a fellow with them in addition to his role. And he's also an officer in the Surfaces and Biomaterials Society, or whatever they are. So, sorry, I lost it there. Landon, without further ado, the floor is yours.
Thanks for the introduction, Duncan. Let me pull up my presentation. So yeah, as Edgar mentioned, it's 5 a.m. here in California, so welcome to my espresso-fueled presentation this morning. Like they said, my name is Landon Nash from Shape Memory Medical, and I'm excited to be here to share our early experiences with the Trellix embolic coil. So just a brief overview of the company. Shape Memory Medical was founded in 2009, and we're currently headquartered in Santa Clara, and we have 22 full-time employees. And our technology came out of Lawrence Livermore National Lab in the Bay Area, and then also Texas A&M University, where it was incubated, and where Duncan is a professor, and I did my dissertation. We have numerous patents around this technology, not only for neurovascular embolization, but for other embolization and other medical indications. Right now, we have 3 commercially available products. So the first one is the Impede embolization plug, where we have FDA clearance, CE marking, and Japan clearance. And that's this peripheral occlusion plug here. It has an anchoring coil that anchors it in the vessel, and then over time it expands to occlude that vessel. The second product we have is this Impede FX, which is very similar to Impede, but without the anchor coil. and it is indicated for peripheral occlusion as well. But what we're talking about today is our Trellix neurovascular implant, which has CE marking, and that's shown here. And for all of these products, you see it's delivered in this compressed low profile geometry, and then it expands to get more volumetric occlusion. So Shape Memory Medical is commonly misperceived as a nitinol company, but we are definitely a polymer company. And that is the foundation of all our devices. These shape memory polymers are porous polymeric materials, and they transition from this compressed, low profile, minimally invasive state. And when it's exposed to body temperature and the aqueous blood environment, that is what actually triggers it for this shape change. So that's another misconception. This expansion here is a physical shape change. It's not like a hydration or a swelling similar to a hydrogel or something like that. It's actually physically opening up. So we can make these polymers in all kinds of shapes. You know, you could make it into a self-tightening suture or something like that because it's a shape change. But for embolization, it just happens to be advantageous to make it into this porous morphology, and that's what we've done. Another thing I want to drive home is this mechanism, it requires heat and moisture, so both, not just one or the other. So this is a plot of the material stiffness versus temperature, and this inflection point is the temperature at which that polymer will expand. So when you first take it out of the package, it's dry and the transition is quite high. And then once you introduce it into the blood, over time, it will slowly plasticize over the indicated working time until that transition temperature is right at body temperature. And at that point, it can expand. So if you were to take these devices out and just saturate them in room temperature saline, even for an hour or several hours, it's not going to expand because you need that temperature input as well. The other thing to point out is once the material goes through that transition, since this is the material stiffness, you see that it's dropping orders of magnitude. And that's advantageous for these aneurysm applications because the expanded material is very soft and it's not imparting a lot of pressure against that aneurysm wall once it's expanded. So there are a number of advantages of using this type of coating when compared to bare platinum coils, for example. One is you get stable clot formation. So because we have this porous interconnected morphology of the foam, you get small interconnected clots that form rapidly throughout the scaffold. So you have this composite of both foam, which is the tissue scaffold, and then the thrombus that's developed not only around it, but within it as well. Additionally, when you look at the expanded coil, only about 1/8 of the material volume is actual radiodense platinum. So you can visualize a lot more through the coil mass, which I'll show in some of our clinical examples. The other advantage is we get increased packing density. So we advise physicians to pack aneurysms just like they normally would to just their normal target packing densities. But then over time, that foam continues to expand and fill all the interstitial spaces between the adjacent coils, and that really improves our packing density. And then finally, over time, we get accelerated healing because our polymers are biodegradable, which elicits a robust healing response, which is supported by our preclinical results. So obviously, we're not the first company that's put polymer coatings over platinum coils for embolization. I want to highlight two polymer-coated coils and kind of really delineate how we're different. So the first is hydrocoils, and this is an expanding acrylamide hydrogel. And the difference with this coil is that it's volume occupying. So this hydrogel is hydrating and swelling in response to moisture, and it's basically displacing the thrombus And it's also non-degradable, so that material stays in the aneurysm site, for the lifetime of the patient. And that's different from our kind of thrombus including material that degrades over time. And the other augmented coil that I want to highlight are the matrix coils. So these coils had a PGA PLLA fiber coating, and it was originally designed to elicit that acute inflammation response to drive healing and subsequent scar formation. But the problem with these coils is the mechanism of degradation for that coating was a passive hydrolysis. So it just breaks down when exposed to water. And in vivo, that would lead to very rapid degradation. So this coating would just disintegrate in a very short order and leave large voids within the coil mass, and that's what led to the coil compaction and then high recanalization rates. And for that reason, it's no longer marketed. So the way that we're distinctly different from matrix, if you look at these in vitro studies of just the polymer itself, here, the original foam, it's hydrolytically stable. So if you put it in a basic environment for 14 weeks, we maintain 100% of the mass, and the morphology is largely intact. However, if you put the same material in an oxidative environment, so here it is in 3% hydrogen peroxide for 14 weeks, you can see that the material is starting to degrade and that morphology is breaking down. And then here you can see a variety of different concentrations of hydrogen peroxide is leading to significant mass loss. So this oxidative mechanism is in line with what the material sees in vivo as the immune response responds to this foreign body material. Macrophages and other immune cells are secreting reactive oxygen species. So you have this cell-mediated degradation of the material over time. So just to drive home the full life cycle and why we think these materials are beneficial for durable occlusion is you have your shape memory polymer foam. It's a porous, high surface area scaffold. It's biocompatible, non-inflammatory, and the morphology of the foam itself is creating a lot of hemostasis. It's altering the hemodynamics within the aneurysm, and the high surface area all lead to very rapid thrombosis acutely. But then chronically over time, the foam is serving as a tissue scaffold, and as it's degraded and the thrombus is being remodeled, it's being replaced with stable collagenous scar, and that's what leads to the durable occlusion. So this is a slide from one of our preclinical studies. This is actually a parent vessel occlusion. So in this very small box here is the vessel cross section, and then this little ribbon here is a single polymer membrane of our material. So this purple box here is blown up in this TEM image. And in this image, this very dark band here is the actual polymer itself. And you can see that this multinucleated giant cell is a large white blood cell that is attacking and removing this material. But this cell is also signaling fibroblasts to come in, and it's depositing mature fibrillar collagen right adjacent to the material. So this is showing that not only is the material biocompatible, but the degradation products are also biocompatible, and we're getting this cell-mediated degradation and collagen deposition. So we don't have this level of detail for every single one of our preclinical studies, but this very magnified image supports what we see kind of macroscopically in our histology. So this is a porcine vein pouch aneurysm model, and this is just a this is the S&P only, so it's not the Trellix coil. There's no metal component, but here you can see that the throughout the full volume of the aneurysm, we have collagen, which is staining teal, dispersed throughout the entire aneurysm. And then if we look at the gross pathology, you can see this thick neointima lining that's developing. And the other thing that I want to point out is comparing the aneurysm volume at 90 days to 180 days, the aneurysm volume in this lesion is significantly shrinking. So this fibrillar collagen that's being deposited is a contractile tissue, and it's really bringing in the entire aneurysm lesion and shrinking it over time, versus like in the bare platinum case, those coils, they're compressing along this axis, but the coils kind of truss that lesion open. So this is our preclinical study for the actual Trellix foam-coated coil. So this top row are bare platinum coils compared to the Trellix group. And here you can see at 30 days, these yellow bits are the actual residual foam that remain in the aneurysm. At 90 days, that material is largely gone. And then by 180 days, the foam has been completely biodegraded. And if we compare these two groups quantitatively, you can see that there is more rapid collagen deposition when compared to the bare platinum group. Another thing I want to highlight from our preclinical study with Trellix is that at all time points, we had a statistically significant thicker neointima when compared to our bare platinum group. So I mentioned it a little bit earlier, but a big clinical advantage that we've seen with Trellix is the fact that there is significantly less metal. So as you know, with traditional coils, if you have a large coil mass, this coil mass is completely attenuating all of the x-rays that are passing through. So you can't really visualize at the center of the aneurysm or behind the coil mass. And there are situations where there could be a little bit of patent flow into this mass that you can't visualize. So then at that point, you're going purely by feel. Compare that with Trellix. Here you can see, this seems like a sparsely packed coil mass, but what you can't visualize under X-ray is all that expanded foam between the coil loops and the developing thrombus. And so under an angiogram, you can really tell if contrast is infiltrating or not. And not only that, but you can visualize vessels behind the coil mass to make sure that they're still patent. So we view that as a clinical advantage for this particular device, especially for very large lesions. So just to give a brief overview of all the specifications, we are indicated for a 10-minute working time. So from the point of introducing into the catheter and it contacts moisture, you have 10 minutes to deliver and retrieve and manipulate that coil before you detach. The volumetric expansion from completely compressed to completely expanded is about 3x. The coil starts at about 50 thousandths of an inch crimped and then ultimately expands to 30 thousandths, and then the platinum backbone coil is 8 thousandths of an inch. And as I mentioned, we're indicated for an 021 microcatheter compatibility. Our current catalog size offerings are from 3 to 16 millimeters in diameter and 2 to 20 centimeters in length. And we have titled these as complex fillers because even though the backbone coil is helical, the foam coating, especially once it's sitting into the introducer, it straightens out a little bit. So as it's exiting the catheter and going into the aneurysm, the behavior is much more like a complex coil versus a traditional helical coil. And then finally, we've developed our own custom electrolytic detachment controller, and it is monopolar, so you'll have to ground the needle in order to facilitate detachment. So now probably what you've all been waiting for is some clinical case examples. I have to give a disclaimer that I am an engineer. I'm not a practicing physician, so I'll try to do my best to cover all the clinical examples and do them justice. But the first example is a direct carotid cavernous fistula. So here you can see where those vessels are joined. And this is actually the site where we gained 021 catheter access from the arterial side. And in this case, we only delivered 80 centimeters linear length of coil. So after these 420 centimeters were implanted, we actually lost microcatheter access. So we ballooned the ostium of that fistula for 10 minutes. And afterwards, this was the angiographic result we achieved the day of the procedure. So we were very excited to get this result, especially with so few coils. But obviously, there's a question of how durable is this occlusion with so few coils. But as you can see at the 6-month follow-up, it is in fact a durable occlusion at least out to 6 months. And that's with a very minimal coil volume. So the other, another clinical example is a large aneurysm off the right ICA. So here you can see the baseline angiography. And so here is the baseline, and then here it is immediately post-coiling on the day of the procedure. So you can tell there is quite a bit of contrast still infiltrating this aneurysm. But this particular physician was pretty familiar with our device by the time he did this case, and he was confident that the foam was going to continue to expand and the lesion would continue to thrombose over time. And he was correct, because at 8 months you can see where there was contrast infiltration throughout the majority of this aneurysm. It is now occupied by that expanded foam thrombus and scar formation over time. So looking at this volumetrically, when the device is fully compressed, it only constitutes 9% of volumetric filling, and that's with 260 linear centimeters of device, which is the same volume packing you would get with a traditional 18 system bare platinum coil. Now, once the foam fully expands, now you have 24% of volumetric filling with the same linear length of a Trellix coil. And to get that same packing density, you would have to deliver 600 centimeters of that 18 system coil. So we believe, especially for large aneurysms, that you can minimize the number of devices you need to treat any given aneurysm. So the last example that I want to go over today is a para-ophthalmic aneurysm. So about 9/5, these are the baseline angios. We started by implanting a Trellix 6x20 with balloon assistance, and then we followed up with a 3x12 bare platinum coil. And then it was finished with actually a Leo baby. And here it is immediately post-embolization. And then here's the 8-month follow-up. So we had a stable Raymond Roy 1 at 8 months. And we were happy with this, especially because this aneurysm position has fairly high flow and is at risk of recanalization. And we also didn't observe significant coil compaction. So we were very happy with this clinical result. So just to wrap everything up, we do have CE marking for this device, and we have had a limited European launch this year, which we're pretty happy with, all things considered, with the global pandemic. We have over 75 global cases in all these European countries listed, in addition to Chile, where our first in human clinical trial is taking place. So with that, I want to thank everyone for their attention. Thank you for the invitation to present today, and I look forward to the Q&A session. If there are any questions that we don't cover today, feel free to reach out to me or CEO Ted at these emails. Thank you very much.
Yeah, that's a great talk from Landon. We're gonna continue with Pascal Jabour. Pascal is who doesn't know Pascal? He's a professor of neurological surgery and head of the division of neurovascular and endovascular neurosurgery in the Department of Neurological Surgery at Thomas Jefferson. He is well known in the neurosurgical world. He's given lectures all over the world. He has more than 300 papers published, and he's one of the pioneers in using new devices and radial access for neuroendovascular procedures. So we're gonna go ahead and listen Pascal sharing his experience with robotic treatment of carotid stenting. So I think we have the lecture saved. Alberto, can you start with a PowerPoint, please?
Thank you, Edgar. It's a great pleasure and honor for me to be here. Thank you for the invitation. I'm going to be talking about neuroendovascular robotics. Those are my disclosures. And we all know that the likelihood of a good functional outcome decreases significantly for every 30 minutes of delay in recanalization for stroke. And 34% of stroke patients get to a comprehensive stroke center beyond 12 hours. So there are a lot of pre-hospital delays, and this may be really a problem in terms of strokes. Geographic disparities in stroke outcomes are very well described, and mainly in the stroke belt. And the regional geographic variation are mainly a major cause. People can't get early enough to a comprehensive stroke center to get a mechanical thrombectomy. This is a major paper that showed that under optimal conditions, a large proportion of the US population will be unable to access a comprehensive stroke center within 60 minutes. So what have we accomplished so far? So far, we have been able to act on many variables like devices. As you know, we have all new devices. We are more efficient in opening blocked vessels. You see a lot of new catheters, new stent retrievers. Our screening methods are much better. Now we know much better than before how to choose the patients for mechanical thrombectomy. We got better in timing, in reducing the door-to-needle time. We got better in streamlining the process of stroke and creating stroke networks. We got better with telemedicine. We have more mobile stroke units. We have specialized ICU care and neurointensivists. And then also we got better in prevention. One area of uncharted waters is about to be explored, and we haven't done anything in this area so far, which is remote stroke interventions. So you're all familiar with those famous robots, and I'm talking about a different robot. Doesn't look as sexy maybe as the other robots, but this is how it looks like. And it's like we're telling the patients, you don't have to reach for me, but I will come to you. Maybe in the future, hopefully, I will come to you to be able to do the procedure. So that's the robotic arm, and that's the console. A sheath is placed, and the robotic arm is connected to the catheter, and the operator will sit remotely on this console, and it will manipulate all the devices and catheters, and I'll show you live cases later on. This is the first remote coronary stent that was done 2 years ago in India, and it was around 20 miles away. And that's the operator. He was sitting at a temple in India, and the patient was 20 miles away, and that's the operator manipulating the guide catheters, doing the runs, and at the end, actually placing the coronary stent out there. So this was a big step forward. So this is how the unit looks like. So the remote physician unit of the robotic system will be placed outside the INR room. In our case, in our shop, we placed it in the control room. And you have a high definition screen. You have a joystick, the green one, which manipulates the guide catheters. And this joystick, you can turn it, twist it, or move it forward and backward. You have the wire joystick, which is this one, same thing. It can be turned, twisted, and back, forward. The device joystick is the D, and that's the joystick feedback monitor here. This is, if you look at it here, you enable each time you sit down, and that's will tell you the info about the guide catheter, the guide wire, and then the device. So you can manipulate 3 variables. As for the robotic system, the robotic arm is hooked to the INR table. That's the robotic arm here, and then that's the disposable cassette. And the disposable cassette has different parts, and I'll show you in a movie how those are worked. So first, the sheath attachment. You're gonna pull this and attach it to your sheath. B is the guide catheter rotation module. So you take the guide catheter with the 2-way needle, and then you place it in B, and then you lock it. C is the guide support track. So when you pull, this will go and go around your guide catheter, and this avoids any herniation when you're doing a translational movement. D is the device port for which you'll see there is a manual port, there's the regular device port, and once you open it, I'll show you once we open it. E is the wire rotation module, so you put your wire here all the way. F is the micro adjustment button, so in case you don't want to move the robot all the way with big distance movements, you can adjust by pressing it, and it will give you micro movements because the position of the robot is very important. You don't want to have a lot of tension, or it doesn't have, you can't have a lot of pressure on it. The robotic, G is the robotic arm feedback console. This is very important because this is a user-friendly robot, and it will tell you what's the next step. So you will follow what's written on the screen. And H is the cassette lock. So once you put the cassette, you're going to turn this lock. And I is the robotic toggle button where you press it and you can move your robot. Here, the catheter is ready to be loaded in this open cassette. I'll show you later on. And that's the device port in A. So this is where your device port will go. And then the manual port, you always have a manual port where you place your wire that doesn't have to be manipulated during the procedure. Here you see that the diagnostic catheter is loaded. Here it is with the TUI. And as I said earlier, you have this screen, a small screen that will tell you, which is this one, that will tell you each time what's the next step. So this was one of the first publication on the robot, but they were using it at the lab, not in humans. This is the publication by Gavin Britz, who's done a lot of lab work on the robot. They used it in a porcine model for AVMs. And this is showing how we drape the robot. So as you see here, that's the cassette. For each procedure, you need to put a new cassette. That's the robot being draped. And then this is the positioning the robot. We're opening all the ports here, as you see. And now all the ports are open. Now I'm putting my guide catheter. I'm pulling the sleeve all the way and locking the sleeve in the sheath. As you see here, this is a snuff box, actually, sheath. So it's locked here. And now we're gonna load here whatever devices we wanted to put there. And this is ready to load. That's the micro wire that's getting loaded. That's the device getting loaded here, and everything is closed. This is a case of a diagnostic angiogram. Outside on the console manipulating my SIM2 catheter. So in this robot, you cannot, it doesn't take a 035 or 038. The biggest wire it would take is an 18 wire. That's why if you want to do diagnostics, you can use the SIM2, because the SIM2, you can shape it and hook vessels without the wire. But you will hook proximally, as you know. So here I'm hooking proximally the vessels. you can hook a vert, but you can't hook an internal. You hook the common at that time. If you want to advance and super selectively external or internal, at that time you need to do it manually. In this version of the robot, it doesn't take an 035 or 038 wire. Hopefully in the future it will. So as you see here, I'm manipulating the SIM2 and then I'm catheterizing the vessels. Here it is. I catheterized the right-sided common. This is the first carotid stent, first transradial carotid stent that was done. So here I'm manipulating the guide catheter. And then I'm gonna go up with the wire, cross the lesion with the micro wire. So you see here what's happening when I'm manipulating outside. And this is my guide catheter on the left. Then I'm gonna bring my guide wire, then I'm gonna advance my protection device on top of it. That's what I'm doing now. Then I'm gonna unsheath. And then I'm pulling everything. And this was one of the first transradial robotic carotid stent. This is another case, a right-sided carotid stent. You see the guide catheter is placed. You see this nasty lesion here. So now my fellow is loading the wire. And now I'm gonna cross the lesion with the wire first. Then I'm gonna bring up the protection device. So here I'm manipulating the wire and I'm twisting, I'm crossing the lesion with the wire, as you see here, twisting, and then here it is, we cross the lesion. Now I'm gonna bring my protection device. You see here what's happening in the right corner when I'm manipulating. And here it is, I'm unsheathing my protection device. And then I'm going up with the balloon. You're gonna see now the balloon angioplasty being done. And then I'm gonna pull the balloon, come up with the stent, that's the stent. And then that's the final result.
I'm on floor.
So what's happening actually in the room while we manipulating everything, you see here, all the devices are going in and out, you know, alone. So this is, we're pulling out the stent after we've deployed it, as you see here. Another case of a left-sided carotid stent, shaping the SIM2, advancing our guide catheter in the common. That's another nasty lesion. And protection device being advanced robotically, then we unsheath this, it's open now. That's the final result. And then we got a lot of press about the first transradial stent. And then it was one of the first 3 publications on neuroendovascular robotic. We published this in JNIS. It was a feasibility and proof of principle. We published on diagnostic cerebral angiograms and carotid stents that we've done, the first 10 patients. Those are the characteristics of the patients. Then later on, it just came out in Journal of Neurosurgery. We did a comparison of a manual carotid stent versus robotic assisted carotid stent. We wanted to make sure that we're not having more fluoro time or more contrast or anything like that. We wanted to make sure that this was non-inferior. And actually the result showed that the fluoroscopy time, there was no statistically difference. No statistically difference in the mean contrast used, no statistically difference in the mean radiation exposure. The only thing that was longer is the mean procedure time, because we were still at the learning curve. So the whole procedure took longer because it takes time to prep and drape the robot and things like that. But the most important thing that this didn't translate into an increase in fluoro time or increase in contrast dose or increase in radiation exposure. So we're not compromising any of the patient's safety. It is very exciting to see, and that we're training the next generation fellows on the robotic. They are all excited about it. Those were my fellows with the when we just got the robot. Another fellow that tweeted this. She just did her first carotid stent robotically. And as you know, in the US, the FDA, this is cleared only by the FDA for peripheral procedures, carotid stents, and that's all. And as you know, in countries where they don't have FDA, they can do much more. So it's exactly how you deploy, you go up and unsheath a protection device or anything, you can go up and work intracranially. This is Vitor from Canada, who treated actually intracranial aneurysms with the robot because as I said, there's no FDA preventing that. So we were doing a lot of exciting stuff until this little creature invaded our world and turned our world and the whole world upside down. And, from doing exciting neuroendovascular robotics, we started doing crazy things like this.
We go into the neurosurgery department at Jefferson Hospital's vascular division. Check out this TikTok of Dr. Pascal Jabbour and his team.
No, I'm good.
So many stroke patients who are COVID positive, but the sign says at the end, we are here for you. So glad to see this brave neurovascular team can find a minute for some fun as they spend their days saving lives.
And then we started seeing in the supermarket those weird creatures, and every stroke became like really a big production. This is us and the team walking in to do a stroke in style. Then, so this is in May. The FDA gave an emergency clearance for remdesivir, and in the time of pandemics, endovascular robotics may be the answer for distancing and protecting the team. When we first acquired the robot, we never thought about this because we've never experienced a pandemic. But unfortunately, in the US at this point, we can only do carotid stents at this time. So maybe similar to the expedited approval of certain COVID medications, we should we need to have some expedited approval for remote robotics and doing more stuff with the robot. So I think I showed you that the CorePath robot system was easy to set up, user-friendly for diagnostic and carotid stenting. The advantage of the system is elimination of the physician radiation exposure. As you know, the physician is outside, as well as reduction of any orthopedic injuries associated with high volume procedure, because it's more ergonomic and we don't have to wear lead. Something very important is that is a much better, more accurate microwire microcatheter manipulation. When you manipulate this with the microwire with the joystick, this is a one-to-one. I mean, you twist, you turn, and it's very accurate. So this is clearly more benefit for the patient and more safety for the patient. And maybe the rapid improvements in technology and engineering may potentially enable performing remote stroke interventions. There are a lot of challenges still for that. And then we need the new generation robots. So one of them is the lag with the internet. But I think with the 5G, this may be feasible. As you know, there are a lot of patients that live really far away geographically from a center that's capable of doing a mechanical thrombectomy. And between, sending those patients to a hub hospital where it's going to be too late, and once they get there, nothing can be done, and trying to do this case remotely where they are, where we're giving them a chance at least to do the procedure. Maybe this would be interesting. Again, it is challenging. We need to figure out a lot of things. It's still not at its prime time yet, robotics, but this is the first step, and everything starts with the first step. Also, complications. If a complication happens, it may be a problem if we're far away. What type of physician do you need in this remote hospital, and things like that. So again, we need to figure out a lot of things, but this is just a baby step, and I think we're on the right way. And again, be careful, be aware of technology. It's a double-edged sword.
Emma. 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 Emma.
Okay, thank you very much.
Great talk, Pascal. Duncan, do you guys have any questions? Or I have a couple of questions, but I want to ask everybody, the panelists first, if they have any questions right now.
Sure, we have one question that was typed in about the cost of the robotic system. Can you elaborate on that, Dr. Jabbour?
It depends what package they take, but it's between 500 and $1 million.
Okay. And I have in 1985, I was designing flight controls for airplanes, and doing fly-by-light, meaning there wasn't a mechanical feedback into the joysticks. So and how much, given that interventionists get so much from their tactile feedback, from delivering catheters and guide wires, etc., how is that translated to you, the clinician, in this robotic system?
Absolutely. Haptic feedback is a major challenge to overcome. Right now, with doing those, not intracranially, it's not a big deal, but once it's going to be done intracranially, it is. Now, Vitor has an experience in that, and then he addressed this in his paper real nicely. So, a lot of times we rely a lot on what we're seeing. We train fellows, and we can see sometimes if there's anything that we see at that time, we say, oh, stop, or don't do this. And with the new generation robotic, actually, you can program the robot to a certain resistance to right away stop when it reaches a certain resistance. And also they were working on that. In the lab, I tested that, where if you have if you have a certain resistance, it won't advance anymore. But this is one of the challenges for intracranial procedure. Absolutely, haptic feedback.
Thank you.
Thanks.
Edgar?
I have a question, Pascal. How long does it take to set up the robot? I think from the study, the floor time and everything else takes the same when you do it manually, but what about setting up the robot?
So to set up the robot, if you have an experienced team and after your learning curve, it's just 5 minutes practically. You need to drape it, and then you need to put the cassette and then hook it to the sheath.
Okay.
Yeah.
Okay. And do these patients need to be done under general or still?
No, all my stents on the robot, I do them under sedation.
Okay. Any other questions from the panelists? All right. Well, thank you so much. There was a great talk, Pascal. Thanks for taking time to join us, and hopefully next year in Galapagos.
Yeah, thank you for the opportunity, and yeah, hopefully see you next year.
Thank you.
Thank you.
Thank you.
So Next speaker is Dr. Rishi Gupta. Dr. Gupta is the director for stroke and the neuroscience and neurocritical care at Wellstar Health System. It's a large health system in Atlanta, Georgia. Dr. Gupta is also the PI for the Tiger Retriever, which is a device that we were lucky to be part of the trial here in the US. And he's gonna share some of his experience with this new thrombectomy device that is new to the States because already been used extensively in Europe. Thank you, Rishi.
Thank you, Edgar. Let's see here. Okay, can you hear me okay?
Yes.
Okay, great. So thank you for the kind invitation. And so I'm going to talk about the Tiger Retriever, which is a novel thrombectomy device. So the purpose of today's talk is to talk about the European experience, the recently completed US experience, and then kind of the next generation devices for distal vessel occlusions. Next slide, let's see. Can't control this. Okay. I don't know, like I'm having some trouble. I apologize. Are you able to advance the slide for me? Okay, thanks. Sorry, I can't. Yeah, I'm having issues on this side. Okay, so the Tiger Retriever is a novel device because it has a handheld technology where the operator is able to expand and deflate the device with this control device. So each click allows for a gentle expansion of the device. And the operator can visualize as the device opens intracranially and expand to the vessel diameter of target. The technique allows for what's called a massage technique, where the operator can gently open and then deflate the device to try to engage the clot and try to allow the clot to fall within the mesh of the device. And so as you expand, there is foreshortening that occurs. If you overexpand, there can be invagination of the proximal, the distal part of the device. The little tip at the end is a soft 006 wire, but that's what the device looks like. Just from a contrast standpoint, the device does have a little bit higher radial force than the current generation of Trevo and Solitaire. Okay, next slide. There we go. So there are currently, yeah, that's it. So there are currently 3 Tiger Retriever devices that are available abroad, not in the United States currently. So the Tiger 21 is the sort of the workhorse device, and it was conceived for M1 and carotid terminus occlusions. So the device can expand up to, for a 6 millimeter vessel, goes through an 021 microcatheter, and can be, as you can see here, was conceived of for M1 and carotid terminus lesions, maybe proximal M2s. The Tiger 17 goes through an 017 microcatheter and was conceived of to be used for M2 and M3 occlusions, and can go down to an 0.5 millimeter vessel. The maximal size will be a 3 millimeter vessel, and does have a higher radial force than the Tiger 21. So there has to be a little bit more care with this device. And then the last one is the Tiger 13, which is really, there's been no experience in the United States, but has been used in Europe, and is really for M3, M4, distal ACAs, perhaps even pica branch occlusion. So this one goes through a much smaller 013 microcatheter, and you can see here some of the branch occlusions that could be used for. Next slide. So the Swiss registry data was the first experience with the Tiger Retriever, and this was a prospective multi-center trial. And what they did was they looked at patients who came in with large vessel occlusive disease. They did 30 consecutive patients, and they treated with the Tiger 21 or Tiger 17 device. You can see here that the majority of occlusions were MCA, M1 or M2. There were some posterior circulation clots. The median NIH stroke scale was 11, and the median time to treatment was right around 5 hours. The groin to recanalization time was 50 minutes. and TPA was given to nearly half the population. Next slide. And so you can see here that the TICI-2B3 reperfusion rate was 94%. The first pass effect, for achieving TICI-2B or more, was 63%. And you can see the NIH stroke scale did drop substantially for this small cohort. And the modified Rankin 0 to 2 at 90 days was 83% for this cohort. So keep in mind, this is a small 30-patient cohort. It was prospective, but there's always center bias with a single center study. This was not adjudicated by a core lab. So this was site adjudicated. Based on their experience, there were no SIH, no symptomatic hemorrhages at their site. There was one symptomatic hemorrhage that occurred during a bailout maneuver. It was felt not due to Tiger, but to another device. Next slide. So this initial experience in Germany and then the Swiss trial led to the Tiger US IDE study, which was the Tiger Retriever large vessel occlusives trial. It was used for the Tiger 17 and Tiger 21 devices. Next slide. So the study was just completed, and there are 160 patients enrolled, 17 sites. You can see here that the distribution of centers involved. Edgar and University of Iowa was one of the participants, so thank you for enrolling. But you can see here the distribution, and the study was just completed, and the results are going to be presented at the International Stroke Conference in February 21. So unfortunately, I can't reveal the data, but this was a independent core lab adjudicated by David Liebskind at UCLA, and the data has just been cleansed, and so we're just waiting for the final results before publication. Next slide. So again, this was a single arm registry just to achieve 510K clearance in the United States. But so here's some cases just to give you an idea of what the device in real time looks like. You can see here that here's a patient, a 75-year-old patient who presents with a carotid terminus M1 occlusion. What I really want you to pay attention to is where the clot is in the device and how much of it has been internalized versus how much of it is externalized on the device. And a lot of this is still, I think, a learning curve. I will say we enrolled 31 in the trial, and there was definitely a steep learning curve to using this device. But you can see in several cases what was seen was this internalization of the clot that, hopefully the hope is that that does alleviate the distal embolization. Next slide. So here's a carotid terminus occlusion. You can see here the tail of the clot is a little bit outside the device, but the majority of the clot has been internalized into the device. And you can see the patient came in with an NH of 21, one pass, TICI-3, achieved NH of 12 at 24 hours and 10 at discharge. Next slide. So this brings us to, how far can you go? So are we done with large vessel occlusions? I know there have been a lot of papers that have been written about medium vessel occlusions and what is the definition of a distal vessel versus a medium vessel occlusion. And I think technologies that allow us to take microcatheters as well as devices further may make this procedure safer. Next slide. And so one of the new concepts is, so here's an example from René Chapeau in Essen. And you can see here, he started with the right M1 occlusion, treated this with solitaire, achieved what I think many of us would consider a successful reperfusion. Clearly at least a TICI-2B. There's a distal A3, A4 anterior cerebral artery clot you can see in the red circle. And I think at this time he had access to the Tiger 13, so he proceeded with treating this small clot. Next slide. And you can see here that the microcatheter is advanced into this anterior cerebral artery branch. Oh, right there, yeah. And so this miniaturized stent retriever you can see in the top right corner, you can see the clot. It's a fairly sizable blood clot that's been extricated from this lesion. So, one pass, he was able to remove it without any complications. and achieve successful reperfusion of this branch. So I think many would argue, like, is that, and I think many people would like to say, why treat that? I think we should all think about from a big picture standpoint. Even though we've achieved Rankin of 0 to 2 in 50% of the population in many of these trials, there is a big difference between a Rankin of 0 and Rankin of 1 and a Rankin of 2 from a quality of life and independence standpoint. And I think, I'm not saying that we have the data to do these kinds of procedures right now, but I think that's the premise of looking at perhaps either salvage therapy from distal embolization or perhaps primary occlusive therapy treating of these smaller devices. Next slide. And so here's another case. This was done in Switzerland, a distal ACA occlusion. And again, you can see the small clot that was removed. This actually looks like more like an MCA occlusion as this is an ACA occlusion, but this looks more like an M3, M4. And you can see that there's a small clot that was removed with the Tiger 13 with one pass. This patient was ineligible for TPA and was treated with one pass. Next slide. This is the last example of an A2 clot. I think you can see here this patient has an anterior occlusion. I think many of us in the United States could use a Trevo 3mm device, perhaps an aspiration catheter to try to remove this clot, maybe lytics. But again, with an SL10, you can take a SL10 across this clot, use a Tiger 13, and remove the clot as seen here. So there were 13, the data was from 26 cases in Germany. So this was Renee Chapeau's series. There was 25 consecutive cases with 26 distal occlusions, and you can see that 15 were primary, 11 were secondary after LVO mechanical thrombectomy. So 9 were in the target territory. Of those 11, 9 were in the target territory, 2 were ENTs in another territory, and these 26 lesions were treated. Next slide. And you can see here that there was, the mean age was roughly the same in both groups. There was an NIH stroke scale, kind of as expected would be more medium. These aren't large vessel occlusions, so 8 to 9. The onset to groin puncture was fast, within 3 hours. And you can see the onset of groin puncture recanalization was 50 minutes in the primary recanalization group. So it does not seem to be longer than treating a large vessel occlusion. It's in the same ballpark. Next slide. So the TICI 2B3 for this cohort was 92%. There was an improvement in NIH stroke scale after these procedures. There were no deaths and no symptomatic hemorrhages reported for these 25 clots, and no unanticipated device-related adverse events. There were 4 asymptomatic hemorrhages. Again, these are site adjudicated, not core lab adjudicated, so we always have to take that with a grain of salt. But nonetheless, it's encouraging that if these kinds of procedures can be done safely, there may be an avenue for this kind of technology. Next slide. So in conclusion, from the US IDE study, from the European experience, the Tiger Retriever was safe and effective for treating acute stroke based on registry data from Europe. The US IDE study will give us a prospective core lab adjudicated results of the device. So we'll see what those results show when it's presented at the ISC in 2021. I think that one of the theoretical advantages of the device is that you can repeatedly expand and compress the device for theoretical better clot capture. But I think also for the operator control of how much expansion and deflation of the device the operator would like to do based on the size of the vessel. I think the Tiger 13 is an exciting new technology. The company is looking at doing a study here in the United States with the Tiger 13 device. And so that's being conceived of right now with FDA submission. So that's also an exciting advancement for the field to assess if distal vessel occlusion may be a treatable lesion for interventionists in the future. Thank you so much.
Great. Thank you. Wonderful talk. May we get, yeah, great. Dr. Nash is up too. So now we have essentially a panel discussion with Dr. Gupta and Dr. Nash, discuss their respective talks and or any other topics that want to come up. But why don't we go through some of the questions that have been posted. And I will remind people on the YouTube live chat, you can post questions as we continue through this panel discussion. So I'll start off with Dr. Gupta. So is there a need to adjust the diameter of the tiger retriever as you're pulling it proximally after you've captured the clot?
That's a good question. So the after you've actually engaged the clot, so there's kind of different techniques to this, and I think Edgar can attest to this too. I think there's a steep learning curve, but when you put the initial tension on the device, if you feel resistance, you can deflate it to alleviate that tension, and that allows you, that I think sometimes with stent retrievers, once you have that tension, you have no bailout. You have to either resheath it with a microcatheter and then pull it out, but there really isn't a true bailout. So with this, you can actually deflate the device and then pull it out. Once you've actually relieved the tension and pulled it, the company recommends that you completely deflate the device as you're coming around the carotid terminus and into your guide sheath. And so to answer your question, you're actually completely collapsing the device. And
Great, thank you. And another question I had that is a quick follow on that is what are some of the examples of the learning curve hurdles that clinicians are going through as they're learning to use the tiger retriever? Yeah,
so I do think tiger retriever has a higher radial force than traditional stent retriever. So the advantage of that is those hard clots. I do think it allows an avenue to potentially remove those without multiple passes. But I think that there is an experience of how much to inflate the device, how much tension to pull on the device. I think in theory, with higher radial force, there's trauma. You can cause trauma to the vessel. You can tear the vessel. So I do think you have to be careful with that. So I think part of it is how many inflation. So there's times when you click and you see the device doesn't inflate at all, for example, and I think it's engaged in hard clot or it's on a turn. And so you have to understand that you may be in an inadequate position. You need to reposition your device and then try to re-inflate the device. So that's one example. 2 is how many times to inflate and deflate the device. And 3 is as you're retrieving, how much tension you accept on the pullback of the device. So I think those are 3 parameters you have to really play with.
So I can comment on that. Obviously I don't have as much experience as Rishi with the device, but for me the learning experience was that it's very interesting how the device works because as you open up the device, you go clicking, and as Rishi mentioned, it's tempting to over-click it because also it's very opaque. So it's a one-on-one interaction between the clicking and the visualization of the device expanding. So when I was starting my first cases, I was over-clicking, and then it was harder to really retrieve the device because the radial force is higher. The other issue that I encountered was I usually go, when you are doing thrombectomy, you want to put your aspiration catheter as distal as you can, so you can retrieve the stent retriever inside the aspiration catheter. If you don't completely unclick the device, you're not going to be able to retrieve the stent retriever inside the aspiration catheter. So that's something I learned. But having said that, it's very interesting, especially that you really see the device expanding and you feel that you have 100% control of the device as you click it and as you see how the device accommodates to the vessel where you're trying to do the thrombectomy. So those were the main learning points for me in using tiger retriever.
I think that's well said. I think you have to deflate the device before pulling it through an aspiration catheter. It does overexpand.
And Rishi, a very specific question is: can the Tiger 13 go through a marathon microcatheter?
I don't know the answer to that question. That's a great question. I I can get you that answer. It should go through technically. It's theoretically designed to go through an 013 microcatheter. So I don't know specifically if it'll go through a marathon or not, but it is designed to go through an 013.
Okay. And one more, and then we'll get some for Landon here. But it is, can you review again why the Tiger Retriever is so soft compared to the stent retriever?
Yeah, I wouldn't say it's soft. I would say it has more radial force. So I wouldn't say soft. I think that the only, like I think as Edgar had alluded to, I mean, you have control over the expansion. So if you're dealing with like a let's say it's a small M1 and you don't want to use a 4mm device, for example, this gives you control to expand it to 2 to 3. I mean, you have that, each click allows you a iterative click, allows you to expand to the size of the vessel. So I wouldn't call it soft per se, but I would just say it's size appropriate.
Great, thank you.
One question, please. Can you need to use to stop the flow when you are retrieving?
So like a balloon, like a balloon guide?
Yeah.
Yeah. So in Switzerland and in Germany, the experience was all done with balloon guide without aspiration catheters. That was kind of their predominant go-to. So you absolutely can do just a balloon guide and the stent retriever, like any other stent retriever. I think Edgar and myself, we tend to use more of the proximal aspiration, the SMAT technique, or the trap technique. So I think that has been sort of my comfort level, and that's what I do. But yes, absolutely, you can use a balloon guide.
Landon, so here's a question, and I'll expand on it. Is Trellix indicated only for large size aneurysms? And can you go over a little bit of in Europe what the indications are and or what the preferential types of aneurysms for treatment?
Right. So
size cut off too.
Yeah, our indications don't limit us to any particular aneurysm, but anecdotally, Trellix is better suited for larger aneurysms. I think that's really addressing the unmet need for recanalization in larger aneurysms. Internally, like for our clinical trials, the acceptance criteria of patients enrolling, we need a minimum of 5 millimeters along all axes of the aneurysms. And I think that's a good rule of thumb, especially for the first few patients that you do, because in terms of handling, there is a little bit higher perceived friction in those smaller lesions as the foam coating is adjacent to the aneurysm wall.
And you mentioned trial. Can you expand on where is this in going to the U.S. and what trials are engaged right now, or where are we at?
Our first in human clinical trial in Chile right now. We've done cases in Santiago and then a few in Concepcion. And then relative for the US, we've submitted our 510(k) application and we're preparing our IDE submission for a US trial.
Okay. And another one that was posted is, where is there a summary of the European cases? And number of sites active now. So
that is correct. So we have a designated sales and clinical support person in Europe. She's located in Germany, and she's been able to travel a fair amount given, the pandemic. But we have a training model that circulates body temperature water in the aneurysm model, and we try to advocate for any new physicians to do training with that model, to try to get some of the nuance of the device prior to their first cases. So the majority of European cases have been done in Denmark and Poland, and then we're getting more traction in Germany and the UK.
Great, thanks.
No, I have a question, sorry, for Landon. I had a chance to use the coil in Lima, and it's a pretty neat system. You mentioned that the aneurysm shrinks, which is, it's interesting because, for example, when we treat PCOM aneurysms that sometimes are pressing on the third nerve, there is also a controversy from neurosurgery saying for this type of cases, better to clip the aneurysm because you remove some of the volume of the aneurysm. And the endovascular guys say it doesn't matter because with the coiling, the aneurysm is not going to expand and you take some of the pulsation of the equation. So, mentioning, you said that in some of the follow-ups, the aneurysm will shrink because the component will shrink. Is that something you have seen at least, or is there any European experience in treating PCOM aneurysms, or any clinical follow-up when they have seen that actually the aneurysm mass shrinks?
Not yet, but it's definitely something that we're monitoring. And yeah, PCOMs especially is something to keep an eye out for. All of the shrinkage that we've seen anecdotally is in our preclinical because we have the histology and everything. But we do try to at least qualitatively see if that mass has shrunk, but we haven't quantified it.
Rishi, can you elaborate on the leading distal coil that's on the Tiger Retriever? What's the purpose of that? And
The wire tip?
The wire
leading
tip.
wire tip. Yeah. So I think it allows for sort of a closed, if you look at the solitaire device, it's open at the end.
Right.
So this allows for the mesh to be closed on the distal end. So that, again, the theory is just distal embolization or averting distal embolization like a basket. I think that's obviously very controversial because like EmboTrap also has that little distal end tip on it, and as does Trevo. So yeah, I don't know if that really gives an advantage or not. I think that's all theoretical as to the open cell versus closed cell.
So I've designed failed retrievers, thrombectomy devices. So doesn't that length give you some disadvantage that you need to be able to have it, distal to the clot?
Yeah. So I think this technology, I think most technologies, there's a sweet spot where you want the clot relative to the stent retriever. So that sweet spot tends to be right in the middle of the device in most devices. This one, actually, you want about 2/3 of the device distal to the clot and about 1/3 engaged in the clot. So I think there is a little different technical aspect to what you're describing. So one of the disadvantages of the length is that as the vessel does get smaller, as you go more distal or it's on a tortuous turn, I think length can play a disadvantage to that. But I think, like, to put this in context, this device is about 23 millimeters, whereas like the solitaire is more like 40 and the Trevo runs from 30 to 40. So I think most companies are going longer. And so I think there's probably going to be some sweet spot there. And I think they're allowed to go longer because it's uniform distribution of their radial force. I think with this device, it has a little bit unequal distribution. And so I think they've decided to go a little bit shorter with their technology.
And to be an equal opportunity challenger, Landon, the 21,000th microcatheter, is there anything on the horizon to go to smaller microcatheters? And
yeah, absolutely. Kind of combining your question with Edgar's question, ultimately the end game is having a foam only device embodiment that is 17 compatible, because then we can access more aneurysms and really capitalize on that shrinking component of the healing. So you would need some type of neck bridge in conjunction with a foam only device, most likely. But that's really where we're trying to move. The foam coated coil was mostly selected based on regulatory strategy to get through the 510K, and then hopefully we can be our own predicate for a subsequent foam device.
Great.
I have another comment, sorry, for Rishi, and I don't know if you have used the stent retriever, and this is because we heard a talk from somebody from Spain saying that they've been using the device for vasospasm, and it's not only the the Tiger but also the Comaneci The reason for that is because the tools that we have now for vasospasm are either intraarterial calcium channel blockers and balloons. The caveat with the balloon is that sometimes you cannot control how much you're going to be inflating the balloon and can be dangerous. You can rupture the artery. For this device, like either the Comaneci or the Tiger Fever, when you click, you have 100% control how much you're expanding the device. Have you been able to, I know this is off-label and it's obviously off the market, but have you been able to use the device for these cases?
So the Comaneci is available in the United States for aneurysm bridging. So if you're going to coil an aneurysm, a wide-necked aneurysm or a ruptured aneurysm, I do think some people, and I think, those of us who went through training maybe over 10 years ago, I think we're more facile with balloons than perhaps fellows are today. So I think there's a little bit more discomfort with balloons. So the Comaneci device, I think, is more familiar to many operators because you can expand the device across the neck of the aneurysm, coil the aneurysm, and then deflate and remove, without arresting flow. There's no flow arrest. So I think that concept is attractive to many operators. I have used Comaneci off-label for vasospasm, but where I've used it is mostly the anterior cerebral artery because I find that to be technically challenging for balloons in general to, navigate. Plus, as you said, I'm always afraid of rupturing the vessel. So it's a double-edged sword. I'll tell you, it's safer. I think it's safer to do the Comaneci, but it does not give you the radiographic results a balloon gives you, if that makes sense. I think the radial force is less than a balloon, so you're not going to get that, that beautiful looking picture. I mean, the question is always, is making, 70% or 80% down to 50%, is that acceptable? I mean, I think that's something science has to still work through. But I think technically it's much safer. There's no doubt in my mind, because you can take an SL10 or, an 0165 microcatheter, take Comaneci, deploy it, and just gently go down the vessel, and you're done. But I have a hard time because it's just been a handful of cases. I don't know the durability of it. Do you have to go back again and treat it again? I know with balloons, once you do it, it's usually one and done.
Thank you.
So I don't have any other questions on the panel?
Maybe, Nash, can you tell me how hard it is to put inside the coil? Usually with the different coils, like matrix or hydrocoils, hydrocoils we had to steam first to make it softer. Mm-hmm. So you need something else to make it softer, so it can get better in the aneurysm.
So it only takes, by the time you introduce and get it all the way to the aneurysm site, it's sufficiently warm to begin softening. There is a little bit of learning curve in terms of the overall feel of the coil. One thing that's interesting is if you maintain constant compression on the coil. So, with a elastic bare platinum coil, you push until the force is too high, and then your instinct is to back off, right? And the force is linear. It goes up and then it comes back down when you unload. With the Trellix coil, what we advise physicians to do is push until they're almost uncomfortable, and then you hold that static compression. And what happens with the polymer is it will actually relax and then it will fold. So we call that the wait and break. So if you hold that constant forward compression, and it may take as long as 10 seconds, but then you'll see that coil will fall into place. And that's something that's not typical of most coils.
Great. Anything else? Well, I'd like to thank Edgar and Garan. I like this new cutting edge technology session. I really wish we were about to go walk for lunch in the Galapagos, but It's wonderful interacting with you all, and thank you to all the speakers. Very, very, very nice talks.
Well, thank you so much. It's awesome.
Yeah, thanks everybody. Thanks Duncan, Rishi, and Landon. You know, it's we try to keep it short because we appreciate everybody's time, and hopefully we'll reorganize it for the Galapagos in the coming years.
Sounds great.
Hope so.
Thank you very much.
Thank
It's
you.
been great.
Thank
Bye.
you.
Thank you. Bye-bye.
Thank you. Bye bye.
Yeah, I think yeah, we're right on time. So I think Dr. Turner takes over. Just a brief introduction of Dr. Turner. You know, I've been lucky to join University of Iowa. You know, Dr. Turner was the you know, he did all the statistics, and there was the statistical PI for ECUIA. So he has a vast experience of aneurysm research, and we've been lucky that he agreed to moderate this session. And please, if you can proceed, Dr. Turner, thank you.
Thank you, Edgar. Yeah, I started out in subarachnoid hemorrhage and then moved into unruptured aneurysm. So it's kind of like our next speaker, Mergwin Verguin, who's from the University of Medical Center at Utrecht. He's an associate professor and stroke neurologist. Mervin's also started out in subarachnoid hemorrhage, looking at the consequences and complications of subarachnoid hemorrhage, including vasospasm, and then also has looked at risk factors. And like me, he's moved into the idea of how can we look at unruptured aneurysms in terms of predicting hemorrhage and how we can prevent that. So Merwin is co-PI of the Protect U study. And so Merwin, do you want to take ahead?
Okay, thank you, Jim, for this very nice introduction. I'll share my screen. Do you see it?
Okay.
That's a pity. Sorry for this. Some technical issues here. I thought I had everything in place. But maybe that I have to leave the meeting and log in again. Sorry, 1 second. Alberto, I see that the host disabled attendee screen sharing. Yeah, let's do that. What's your email address? I got it. You got it?
We can switch presentations and have Lou, are you okay presenting before Mervin?
Yes.
Yeah. Okay. So
So it's my turn.
yeah, we can. Are you okay, Mervin, or you wanna do it? We already have the. Okay. Please, Lou. So Lou is, is a superstar. He's PhD. Works with David Hassan in his laboratory. He does all the dirty business for David. He runs the whole lab for him, and he's been very helpful for our group. And he's gonna show some of the experience of the research that he's been doing with David as part of his R1. So if you can please go ahead, Lou, and get started. Thank you.
Thank you, Dr. Samanigo. My name is Yongjun Lu, work at Dr. Hassan's lab, Neurosurgery Department at University of Iowa. I'm happy to have a chance to report of our recent work here. My talk title would be Aspirin decreases risk of aneurysm formation and rupture in male mouse more than female. Intracranial aneurysm happen in the brain blood vessels. There's a few forms and ruptures very dangerous. There are 1 in 50 people has unruptured aneurysm. In every 18 minutes, 1 case rupture. Risky include the family history, high blood pressure, women somehow more dangerous than men. And so far, there's no medicine available. Looks like a surgery is only a choice for treatment for this disease, but still dangerous. So in the previous Hassan Lab and others authors has studied on human patient found aspirin with 325 milligram per day, especially 3 times weekly or daily, will be significant decrease rupture in men. And 15 PGDH level was higher in men than in women. Here is a grouped result. I mean, men and female together to look at all the ratio analyze to say that 3 times weekly or daily will be less smaller order ratio, which means less dangerous. And if we separate the man and the woman, you can see men significant decreased by aspirin, but not for female. And if you look at the plasma, blood plasma 15 PGDH protein by ELISA, you can see man has higher level PGDH than woman. It's down about 32%. That's a human study. Then we look at the mouse model study, aspirin, high dose, 25 milligram per kilogram per day, IP injection, with a significant decrease rupture. 15 PGDH also provide a protective effect. Here is combined male and female together, look at the formation and the rupture. Aspirin somehow is significant decrease the rupture. Then if separated male and female, male has aspirin effect significant, but not for female. Then if you look at the PGDH effect, using inhibitor, PGDH is good, inhibitor make less PGDH, then rupture happened more. Compared to aspirin only, this one is aspirin combined PGDH inhibitor. That's happened in male. And if you use agonist, aspirin and the PGDH agonist, agonist means PGDH more, and that's good one, then make a, good effect, make rupture less. That's in female. And if we don't use aspirin, look at the PGDH only, you can see the aneurysm rupture going down in male and female. So there's two effects, aspirin and the PGDH in animal with aspirin high dose. So from previous study, we may suggest a mechanism for aneurysm rupture by aspirin effect through PGDH pathway. PGDH is good, green is good. PGDH direct effect PGE2. PGE2 is bad, make a rupture happen. PGDH also make a PGE2 become 15 ketone PGE2, which is good agonist for PPAR gamma. PPAR gamma is a good one to make an anti-inflammatory cytokinase. So we can see aspirin blocks COX-2. COX-2 is better one to generate the pro-inflammatory cytokinase, including PGE2. So we have linked together PGDH and aspirin. There are some crosstalk. So that's a mechanism suggested. So from those study, we have hypothesis because we have a high dose before. Now we have aspirin low dose, 5 milligram compared to 25 milligram per kilogram per day. And this low dose comparable to 325 milligram for human. If we divide by human body weight, suppose have 65 kilogram, you can get 5 milligram this dose. Here is our protocol. We have a surgery at day 0. Before that, we got blood pressure measurement by tail cuff. And we measured after surgery in 1 week, measure blood pressure again. During the day 0, we got a surgery. Surgery means we give, elastase injection in brain and implant mini pump for angiotensin II continuously infusion. We keep a monitor daily up to 21 days, then euthanize the mouse and get the brain opened, then do image analyze on the brain artery, and then harvest the brain artery for qPCR using subgreen delta CT method to get the relative message level. We did the 121 mouse. We divided them into 5 groups: angiotensin infusion only, elastase only, and third group is elastase and angiotensin 2 infusion plus vehicle. And the fourth one is elastase angiotensin infusion plus aspirin. And the fifth one, we just use without any treatment, which is used to compare to other groups, also used for qPCR as baseline measurement. Here is the image example. We make the mouse induced aneurysm and look at the brain. I zoom this corner here. You can see the aneurysm happened here, and the ruptured here, hemorrhage, and dilation. The artery become larger. That's a very good example for in our study. Now we have 4 groups. Look at the representative images: no treated, clean; angiotensin 2 only, quite clean; elastase only. You can see the aneurysm and hemorrhage, and angiotensin 2 and elastase, you can see hemorrhage and dilation. Now we have more groups, aspirin groups more. There's 5 groups, and male, female separately. You can see no treated, clean; angiotensin 2 only, clean; elastase, some aneurysm and hemorrhage. And this one is control one without aspirin, but the serious aneurysm and hemorrhage. If treated by aspirin, somehow, protective. So that's schematically show the aspirin protective. Now we look at the angiotensin effect. We measure blood pressure to see the angiotensin 2 will increase the blood pressure. We measured the 4 point before. We started all the measurement, all the mouse. We have some mouse measured 4 point first, before surgery, after surgery, but we found that after surgery, there's no significant difference in 3 weeks, once a week point. So we decided just to measure 2 point before surgery and after surgery. After surgery, about 1 week. So we look at all mouse groups. Looks like before, after, all significantly increased by angiotensin. Here we only show the systolic pressure. So all groups have the significant difference between before and after. Then we look at the body weight. Body weight after surgery will be lost some body weight, but after 11 days become normal. We didn't find the aspirin effect on blood pressure and body weight. Now this one's survival curve. Aspirin effect in male, solid green. Aspirin effect female, dashed green. So it looks like male rescued by aspirin a little bit compared to control. The red one is control, but not for female. Here we show the aneurysm formation and the rupture. Those 2 panels is grouped, combined, which means not to separate male and female. You can see the difference, and here's the summary result. Aspirin effect makes aneurysm decreased, and the rupture decreased. They're all significant. Then we separate, analyze with male and female separately. You can see male and female has some difference for aneurysm formation. Decreased 4 it's become 40% compared to female 80%. They're significantly different, much less aneurysm in male. But the rupture decreased the rupture in male and the female, but not significant. Now, if we use the result to do all the ratio analyzed statistically, we can find aneurysm in male by aspirin. Somehow all the ratio is lower, which means protective. That's happening to male, not in female. Now we look at the gene expression by qPCR in mouse artery after aspirin. We have angiotensin 2 only, elastase only, and placebo as a control, and aspirin treated groups. You can see PGDH is high in male already, higher than female after aspirin treated. The baseline is one, which is no any treatment tissue used as control, reference control to compare all the messenger RNA expression. So placebo higher and aspirin even more high in male. That's the main point we got. So no aspirin significantly higher in male than in female. Aspirin upregulated in male than in female. There are another gene expression in artery, KEAP1. KEAP1 is combined NRF2. NRF2 is good one. KEAP1 is bind to make NRF not released. So if KEAP1 is higher, has less NRF released, which means additional aspirin effect is there. Aspirin costs slightly higher in male than in female, but slightly, it's not a really big difference, but still significant. We still measure the other gene expression after 15 PGDH regulation and aspirin treatment. There are multiple inflammatory cytokinase expression higher in control, but after aspirin treated, become no difference between, not a significant difference between male and female. For example, this one, interleukin-2 is quite high, very high in male compared to female. We compared male to female. But after aspirin treated, they become normal. Not normal, but not significant, different. And this one's a good one. This two is a good one. Used to be higher in control, but after aspirin treated, become not significant difference between male and female. PGDH is special. It's higher in male without aspirin treated, and become higher in male after aspirin treatment. So here's the graph show the all the data. It's individual mouse point. They are variable, but statistically can get the result summarized here. So we can summarize our study here. Before we have human study and mouse study with high dose. Now we have a mouse study with low dose. We can see the aneurysm formation less in male than female, and the rupture lower in man in male than female. And 15 pGDH in brain artery without aspirin is higher already, and with aspirin treated become higher, much higher. So we would say low dose aspirin show the protective effect, decrease aneurysm and rupture. And there is sex differential. Low dose aspirin upregulated 15 pGDH expression in both sexes. And aspirin protection could be associated with PGE2 regulation and 15 pGDH expression in artery. Then we got conclusion. 15 pGDH add additional protective effect besides aspirin protective effect to decrease aneurysm formation and rupture. And now the question is this beneficial effect is due to PGE2 decreased or increased 15 keto PGE2? PGE2 is bad one, 15 keto PGE2 is good one. So that's the question we need to answer in future. So we have future direction for study. We can directly add 15 keto PGE2 to mouse. Second, we will add 15 pGDH inhibitor to mimic knockdown or use knockout, 15 pGDH knockout mouse to study the effect. The third one is use PPA gamma antagonist. PPA gamma is a good one. Antagonist become bad. Then we also can use PPA gamma mutation mouse, which is knock-in. We use human sequence to knock in the mouse to get the dominantly negative mutated PPA gamma in specific cell like endothelial cell or smooth muscle cell in mouse. We will continue this study with 3 directions. So here's schematic one. Directly add 15 keto PGE2 into the mouse. Second is knockout or knockdown PGDH. Third one is mutated or antagonist PPI gamma to see the effect aspirin and 15 pGDH effect in the mouse for the aneurysm. Finally, we will express our thanks to NIH grant to Dr. Hassan for this study. Thank you.
Thank you, Young. Let's go ahead with Mervin. Alberto, are you going to load the slides? Yeah.
Yes, great. Thank you very much. Okay, so it's my pleasure to give you an overview of the PROTECT-U trial, which is currently recruiting patients. And currently this is a Dutch-German effort. I'm one of the 2 co-PIs, and the other co-PI is Professor Nima Edminen from Mannheim, Germany. Next slide, please. So the prevalence of unruptured aneurysms in the adult population is approximately 3%. And most often, these are coincidental findings. For example, if people have head injury or dizziness or TIA, they get a scan of their brain, and then by coincidence, an unruptured aneurysm is found. And that's how these patients end up at our outpatient clinic. Next slide, please. Next slide, please. Yes, this one. So, of course, we all know that aneurysms can be treated to prevent aneurysm rupture. The problem is that severe complications can occur, ischemic strokes, even bleeding from the aneurysm, etc. So usually this is a multidisciplinary decision to treat the aneurysm or to wait and do follow-up imaging. And in our center, approximately 1/3 of the patients have preventive aneurysm treatment, and the other 2/3 are scanned over time. Next slide, please. So this is a very academic decision. We weigh several factors. On the one hand side, the risk of rupture. On the other hand side, the estimated risk of treatment complications. Of course, if the patient is very anxious, we may end up doing preventive treatment, even if there's a low risk of rupture. The patient often accepts the risk of complications. So, but for the other 2/3 of the patients, we follow up over time, and we see them back in the clinic every 1 or 2 years with a new imaging. But for the patient, this often feels like they have a ticking time bomb in their brain. And next question, next slide, please. So the question that we often get from patients is if there's no medical treatment available to decrease the risk of rupture. And currently, such a treatment is not available yet. And that's what we now study in the PROTECT-U trial. Next slide, please. So if you look what the treatable risk factors are for rupture, it's smoking. And of course, every patient with an intracranial aneurysm who smokes gets the advice to quit smoking. Not always easy. Of course, hypertension should be treated. And another treatable risk factor for rupture is inflammation of the aneurysm wall. And what we know from previous studies is that inflammation of the aneurysm wall is associated with aneurysm instability. So it increases the risk of growth and rupture. So this would also be a factor that is available for potential treatment. Next slide, please. So this would be the medical treatment: stop smoking, treat blood pressures, and for treating aneurysm wall inflammation, aspirin may be a good treatment option. Next slide, please. So David Hassan, thanks for joining. I saw you joined the meeting. I was the first one to come with this hypothesis that aspirin may reduce the risk of rupture. He did a post hoc analysis from the IZUYA study, and he found an impressive adjusted odds ratio of 0.27, so decreasing the risk of rupture. There have been later studies, also population-based studies, showing that subarachnoid hemorrhage was less common in patients using aspirin. Next slide, please. And more recent studies, they also looked at the risk of aneurysm growth, comparing patients with and without aspirin. And the first study is a Chinese study recently published. They also showed an impressive hazard ratio with a decreased risk of aneurysm growth in patients using aspirin. And the other studies also from David Hassan's group showing a lower odds of aneurysm growth in patients treating with aspirin. Next slide, please. So what would be the working mechanism? Aspirin inhibits COX-2. There have been a study from David showing that patients who were treated for a while with aspirin had less inflammation of the aneurysm wall compared to those patients who were not treated with aspirin. And what is a very important thing that I always emphasize to the patients before randomization is that in case the aneurysm would rupture while using aspirin, that the data of the literature show that the bleeding is not more severe compared to patients not using aspirin, and also the prognosis is not worse. So then we move to the blood pressure part. A couple of years ago, the results of the SPRINT trial were published, and it was a very large trial in which patients with an increased cardiovascular risk were randomized for 2 different blood pressure targets. The first target is the target that is common, a systolic blood pressure below 140, and the other group was randomized to a systolic blood pressure below 120. The median follow-up was 3.3 years, and they showed a decreased risk of their primary outcome of 0.75, and there was no difference in adverse events. So this trial did not include patients with unruptured aneurysms specifically. So we still don't know if unruptured aneurysm patients should be treated with a more strict blood pressure target. This slide shows an overview of NIMA's review on the worldwide incidence of subarachnoid hemorrhage. It is the blue line here. It shows that the incidence of subarachnoid hemorrhage has decreased over the last few decades, and that corresponded to a global decrease in systolic blood pressures. And of course, this is very indirect evidence, but it may suggest that a lower blood pressure may be beneficial in decreasing the incidence of subarachnoid hemorrhage. So the PROTECT-U trial was designed to assess the hypothesis that a medical treatment strategy decreases the risk of aneurysm growth and rupture compared to care as usual. You see below that the study protocol has been published in the International Journal of Stroke. Next slide, please. So the intervention is a combined intervention. We use aspirin 100 milligrams a day in combination with intensive blood pressure treatment with a systolic blood pressure target below 120. We don't do that ourselves, but we give recommendations to the general practitioner to treat the blood pressure with this target. And we also give the patients a blood pressure measuring device, and we ask them to measure their blood pressures approximately 3 times a week. And if there are sustained increased blood pressures above 120, we ask them to go back to their GP and ask for more antihypertensive drugs. The control group, they get the current treatment, so that's no aspirin, and their systolic blood pressure target is below 140, and we also don't give them a blood pressure measuring device. So we include patients with an intradural saccular unruptured aneurysm that's not treated by endovascular neurosurgical treatment. It's a multi-center randomized controlled trial with a probe design, which means that it's open label, it's not placebo controlled, and it's a blinded outcome assessment. So all imaging is sent to a core lab and the scans are read in a blinded fashion. So those neuroradiologists, they are not aware of the treatment allocation. Next slide, please. So the primary outcome is aneurysm growth or rupture. Of course, because we primarily include quite small aneurysms with a low risk of rupture. If we would power this trial just on aneurysm rupture as a primary outcome, I think we would need more than 10,000 patients who should be followed for a very long time. So we also included aneurysm growth in the primary outcome measure because aneurysm growth is associated with an increased risk of rupture. And we used an increase in aneurysm diameter of at least 1 millimeter on serial imaging. So that should be 2 MRAs or 2 CTAs over time. And the primary outcome is measured after 3 years. Of course, we also have a couple of secondary outcome measures. We look at difference in aneurysm volume and shape. If we take also into account the presentation of Dr. Liu, the previous presentation, of course, we should also take into account new aneurysm formation. If the patient has clipping or coiling of the aneurysm during the study periods, that will be recorded. We have a couple of cardiovascular outcomes, ischemic and hemorrhagic stroke, myocardial infarction, and the adverse event. We do quality of life assessments every 6 months, and we will do a cost effectiveness analysis in the end. So we include the patients in whom it is decided not to treat the aneurysm, but to follow them over time. If we have an 85-year-old patient with a 3 millimeter aneurysm, we wouldn't treat the aneurysm. We wouldn't follow up on this aneurysm. So then the patient will also not be included in the trial. The last imaging should have been done within the last 3 months before randomization. Next slides. These are the most important exclusion criteria. If it's a fusiform or AVM-related aneurysm, we don't include them. If the patient use any other type of antithrombotic drug, that can be a platelet aggregation inhibitor, but also a vitamin K antagonist. Those patients are not included because adding aspirin would increase the risk of bleeding complications, renal failure, participation in another trial, and of course, if there's a very short life expectancy, then shorter than 3 years, it's very likely that the patient will not reach the primary outcome. This is the power calculation. Of course, it's very difficult to do a power calculation. If we look at the studies that I just showed, the effect size of aspirin in those studies is very large. And we were a little bit more conservative in our assumptions for risk reduction. I think with the available studies, just in patients with aneurysms, you could even think about like a 60 to 70% risk reduction. But as I said, we were more conservative. And of course, we also had to take into account that there's a dropout rate, and our estimate is that that will be about 10%. So we need to include 776 patients to analyze 705 patients. These are the questions I most often get. Why are we studying a double intervention? Then I show them these numbers. This is an investigator-initiated clinical trial. If we would only use aspirin as the intervention, the effect size, the estimated effect size would have been smaller. So you need way more patients. And if you do a factorial design, so double randomization, first for yes or no aspirin, and then yes or no intensive blood pressure treatment, you would also need 1,700 patients. And we thought that would not be feasible. So this is what the follow-up visits look like. We see them back every 6 months, and the primary outcome is at 36 months. We keep on following these patients also beyond 36 months. So currently, if the patients give informed consent, they are aware that they can be in the trial for 5 years, and that would increase our power, because if the patient has a longer follow-up period, the chances of having aneurysm growth or rupture will also be larger. Currently, there are 2 funding bodies, one from a private German foundation, the Dr. Schweitzer Stiftung, and also the Dutch Heart Foundation is funding this trial. As I said, Dr. Edmund Nima, he's the co-PI. We have 2 seniors, Gabriel Rinkel and Ala Alga. They're also involved. Next slide, please. So we have 17 centers in Germany and the Netherlands. Canada has obtained funding and obtained ethics approval in Toronto. We're now finalizing paperwork, clinical trial agreement, and an insurance issue to get the trial started in Canada, and hopefully that will be in the beginning of 2021. Finland and Hong Kong are also in the process of getting the trial started, but they still need to obtain funding. So probably that will take longer before they will be able to include patients. So this is the current status. We now have included 203 patients. Most patients were included in Mannheim. They started inclusion as the first center. So you see that there, the centers of the 2 co-PIs included most of the patients, but there are several more centers who included quite a few patients. 203 patients. Of course, I'm very glad that we now included this number, but as in most trials, also we are behind schedule, and the COVID pandemic made it even impossible to include patients for a couple of months. So we will be very happy if the trial will start patient inclusion in other countries to speed up patient recruitment. There's also been a DSMB meeting, last one in last January. By then there were 180 patients included. They were primarily females. So I hope that the hypothesis of Dr. Liu that aspirin doesn't work very well in females does not hold true. To give you a little overview of the aneurysm size of the included patients, you see that most of them had an aneurysm between 3 and 6 millimeters. The DSMB said that we were allowed to continue patient inclusion. So this is the last slide of the presentation. We have a website with the study protocol and also the publication in the International Journal of Stroke, which will give you a little more detail than what I have just said in this presentation. And I'm happy to answer any questions.
Thank you, Mervyn. Do we have any questions?
Mervyn, this is David. Sorry, I didn't join earlier. I just finished another seminar. I was chairing the ACNS educational thing. But so what's the longest follow-up you have so far?
So Mannheim started recruitment in September 2017. So we now have the first 3-year follow-up.
Why not use years per like patient years instead of, because I mean, if you're gonna do the same rate, hopefully you go faster now. We're adding Toronto, Hong Kong, and Finland, but it's gonna take you another 6 years to reach your number, unless you have data that that is not available to us to decide whether you're gonna, stop the study earlier or not. So why not use years per, life years? I mean, Jim can help with that too.
Yeah, well, I agree that the recruitment is slower than expected, but of course there will be also interim analysis by the DSMB. We've been quite conservative in our assessment of effect size, comparing to your post-hoc study from Izuya, and also the more recent studies on the effect of aspirin on aneurysm growth. So maybe from these interim analysis, I'm not sure exactly how that works, but we need to talk then to the DSMB if the sample size should be adjusted, or if the trial can be stopped earlier because the sample size is larger than expected. That could be true. That could happen.
Have you heard anything of trend? I know the DSMB. I hate the DSMB groups, but they gave you any trend or anything?
No.
I mean, by giving you the sign to go forward, that's a good sign. Because if they, so they must seen something.
Well, it's too early because the rate of growth is quite low. And as I said, only the first patient has a 3-year follow-up now last month. So it's impossible to say anything on effect size yet. So the DSMB has primarily looked at safety.
Okay.
There are no safety concerns. There's another thing, because of course we also talk within our executive committee on the recruitment rate. There's the thing that the analysis is now a patient-based analysis, while let's say 10% of the patients has more than one aneurysm. So if we do an aneurysm-based analysis, that would decrease the number of patients needed to reach our effect size. And also the extended follow-up in several patients, so beyond the 3 years, may help us in probably not needing the 776 patients.
Yeah.
I have a question, Mervyn. Are you trying to cluster aneurysm sizes? Because there's probably some bias in terms of trying to recruit patients with smaller aneurysms into the trial versus treating patients with larger aneurysms. Are you controlling for that, or?
We're not exactly controlling for that, but we and also the DSMB will keep an eye that we don't include too many aneurysms smaller than 3 millimeters, because the risk of both growth and rupture is much smaller in those extremely small aneurysms. So they will keep an eye on, we have set a certain limit on the maximum number of patients with a tiny aneurysm that can be included. Of course, we already expected before we started the trial that we were not going to include a lot of large aneurysms, because usually those are the patients that get preventive treatment.
What is your compliance rate, Mervyn? Because when we did our study here, they just killed us, the NIH, about compliance and people already on aspirin for other condition like heart condition. How did you guys control for that?
Well, we don't control for that, but it's an exclusion criterion. So if the patient also already uses aspirin or another platelet aggregation inhibitor for another indication, we just don't randomize the patient. And that's, of course, we see many aneurysms in our clinics, but I think the majority of patients that is not included results from already using a platelet aggregation inhibitor.
So what if the patient, like patient X, you randomize them to the non-aspirin, the control group, and then a year later or 2 years later had a back pain or had some condition and the patient started taking aspirin? Do you censor them out, or what do you do?
They will they will remain in the trial because it's an intention to treat analysis. And don't forget, it's a double intervention. So even if the patient is in the control group and starts using aspirin because he had a TIA, they will still be randomized to a systolic blood pressure target below 140 and not below 120.
That will bias your result.
Oh, sure.
I mean, for us, when we did our design, Jim helped a lot with it. We censored them out. I mean, once they start using, we defined the usage of aspirin, we censored them out for that. So
yes.
Maybe that will even change your, I mean, if you have, I don't know how many people, but that will change your rate. If you really truly believe the aspirin is going to change your natural history.
Yes, so we'll see. But as far as I know, there are very few patients who started using aspirin along the way.
Perfect.
So,
any questions?
Yeah, so there's a question on the chat. If there's any plan on addressing, maybe in the future, a subgroup for fusiform aneurysms?
Yeah, well, the fusiform aneurysms are not included in PROTECT-U, so we won't be able to do a subgroup analysis. We will do a subgroup analysis, so see if there's a differential effect between men and women.
Oh, thank you.
One of the outcomes of PROTECT is aneurysm growth. Is you have established protocol for measuring the growth, because 1 millimeter can go either way, and then you have probably 2 reviewers and a 3rd adjudicator. How is that established? Is it always MRA or CTA?
It can be both, as long as the first and the last scan is the same modality. So 2 MRAs or 2 CTAs, that's most important, and it's the maximum aneurysm size they will look at.
So Merwin, also, is there a process for adjudicating hemorrhage? Not only whether it's subarachnoid hemorrhage, but also aneurysm, other hemorrhage?
Sorry, do you mean aneurysm rupture or other types of hemorrhage?
That or let's say GI hemorrhage or other things. So how does the DSMB evaluate hemorrhage, in other words?
Well, of course, every adverse event has to be notified to the ethics boards. So there's the first investigator from the specific center will report it to the DSMB, and then there's a second reviewer who will investigate if this may be related to. So there are always 2 reviewers who look at the adverse events.
Okay, good.
Excuse me, one question. I don't think, maybe I lose the answer, but do you do ERM for looking for enhancement of the aneurysm wall, if there is a difference in patients with aspirin and without aspirin?
No, we're not doing the aneurysm wall imaging. I know that the people in Toronto, they will incorporate aneurysm wall imaging on randomization. So they will have the chance to see if treatment with aspirin and intensive blood pressure treatment decreases the amount of wall enhancement.
You looked at it, but you had small sample size, correct, Mervyn? Because we looked at it out. We had a bigger sample size than you are. And Jorge is not here. He talked about it. But we found that difference We published it in GNS. So I think that could help enrich your study. But I know in Germany, there's a very concern about gadolinium, so they cannot use gadolinium for imaging. So I know you guys were limited by that.
Yeah, but in Utrecht, we did a cross-sectional study. So this is an interventional trial. So this would be the perfect infrastructure to investigate if the treatment really decreases the amount of wall enhancement. Of course, I would like to implement that also here, but it would make the logistics of including patients more difficult because aneurysm wall imaging is not part of our standard imaging. So then the patient would need to come back another time, and they may have to travel far just to get a scan before randomization. And because recruitment rate is slower than expected, that makes things too difficult.
So there's
although it's very interesting.
Sorry.
Yeah.
So there's a question for Dr. Lu from Dr. Juan Sebral, and he's asking if Lu, have you looked at histology of of aneurysm walls treated with aspirin, and how do they differ from those without treatment? Yes. So the question is if you have looked of the histology of the aneurysm walls that are treated with aspirin, and if so, how do they differ from those that did not receive any treatment?
We didn't do this time, but we did it before in our lab physiology study. But it will be done maybe future.
To answer one, we did in humans. We did our first study back in 2011-12, where we randomized patients to aspirin versus non-aspirin, and that's when we saw the COX-2 and CD68 both decreased. So that's in human. We have several studies on that in human to kind of confirm that, also with formoxicillin enhanced MRI. For mice, we did look at the one published in hypertension paper. We looked at gene and PCRs, and we found decreased inflammation on those. So the next thing for us was to do is a liquid biopsy. And what we're trying to do and thinking about is, bring a patient, and this Mervyn you may well consider, is even a patient that you want to treat, but instead of treat them right away, we push them back 3 months, 4 months for treatment, and then randomize them, especially for the endovascular, because it doesn't matter if they have an aspirin or not, and do a liquid biopsy and see if things can change in microenvironment in the aneurysm. So we're thinking about it. The only problem in the United States is the patient don't want to sit for 3 months or longer. When I did my first study, when we waited 6 months, that was, the patient would call in every day about that. The anxiety there's. Once they decide they want to treat, they want it today instead of tomorrow. So it was very hard to convince them to wait 6 months when we did our tissue biopsy with them. So I hope that answered your question, Warren.
I have a question for Young. You saw the IL-2 was, there was a huge difference of 6,000%, no, between males and females in mice. Are you going to follow up that with some more experiments? How do you explain that? That's very interesting. There was such a huge difference.
Yeah, it's possible. We will do that maybe in future to see the more, samples.
So there's also a group we found when we did the liquid biopsy that there's a difference higher interleukin-17 inside the aneurysm versus the bloods, like systemic. And recently, Brian Ho published, I can't remember which journal, but he looked at females, and he looked at females that have ovarectomy versus non-ovarectomy, and found out that mice with estrogen deficiency increase the risk for aneurysm rupture because of interleukin-17. So this is another cytokine that validated by another lab that shows there's a difference between, at least between menopause and postmenopause. I mean, premenopause and postmenopause female. And so those are three, the 15-PGDH, the interleukin-2, and the IL-17, they could be as potential factors between male and female. We're also looking at the SNPs now, which is specific nucleotides, to see if there's difference between male and female. And also we're going to do transcriptomes and look at the whole RNA. So we're trying to pursue that more, both are going to go in parallel, human and mice. But I want to caution everybody, not everything found in mice can be translated in human. There's a huge, a perfect example, stroke. They found 1,000 compound that helps acute stroke, only one that is being translated, which is the TPA. So I keep saying this, that's number one, is caution the translation, 1-to-1 from human to mice. And then two is most of the experiments, actually the only experiment that we have females is our group. Almost all the experiments that published in the journals on mice and animals only involved males, did not involve females. So we're advocating now that, and I know Mervyn, I applaud you for doing that. You're going to look at the 6 differences, secondary analysis, but also you need to look why we're encouraging people when they look at animals to look at both female and male. And I know the NIH is mandating now any grants that are funded by the NIH now, it has to include both male and female, animal, whatever their choice.
So there's a follow-up question from Dr. Sebral. If there's any data about collagen structure or smooth muscle cells content?
Yeah,
go ahead.
We have, condition set up, cell culture, condition. We will do some cell line or primary cell culture to see the difference.
So to answer your question, Juan, no, there is no difference about collagen content. ETMA, NEMA looked at the C14, and you're familiar with that, Mervyn, but that looked at it in longitudinal study to see that. But there's no studies between male versus female. The group that looked at the smooth muscle phenotype changes are Aaron Dumont from Tulane and Bobby Stark from Miami. They were together. But again, they only looked at male. They did not look at female. So it will be intriguing to see if there's difference in the phenotype change of smooth muscle. There's the synthetic and the other one. And then collagen, there's very few people looked at the collagen, collagen 1 versus collagen 4. And I think the Finnish people did look at that. I know where's now Johanna?
Frozen?
Yeah, Frozen. But he was in Kobe, but now
where he is.
He moved somewhere now.
What's the name of the city?
He became a chair there.
Yeah.
Yeah, he looked at collagen, but looked at it in human and defined classified the aneurysm of 4 types, but that based on collagen. Correct, Mervyn? Correct me if I'm wrong. So there's we haven't looked at male and female difference yet, or either group.
Of the institution is temporary. I don't know how to pronounce.
Yeah.
Yes.
Yeah.
Any other questions? Okay, Edgar, it's up back to you.
Yeah, no, I think that's a great discussion. It's really, I think this, again, this is my 2nd year in the meeting. Last year was organized by David in Iowa, and it's very exciting to have like basic scientists and then discussing with clinicians, clinical trials, bioengineers. So I think it was very productive We're gonna start tomorrow early at 7 a.m. and we're gonna talk more about visual imaging. We have people from Germany, Stanford, somebody presenting from our group about aneurysm wall imaging and enhancement. That seems to be a hot topic right now. And then after that, Pedro Lilig asked us to present his data, 13-year follow-up of PIPE. That's the follow-up from the paper he published in Stroke from the Buenos Aires experience with pipeline. So again, basic science and clinical research. So thanks everybody. Thanks Mervin, David, Dr. Turner, Lou, Herman, and we'll see you guys tomorrow.
Thank you, guys.
See you tomorrow.
Yeah.
Thanks.